Hello everyone, I'm Dr. Amit. Welcome back to our biochemistry series. If you want to stay updated with more high-end medical content, make sure to follow me and subscribe to my YouTube channel at the rate Dr. Amit Official. So today we are diving into a topic that frequently pops up in exams and clinical practice, Marfan syndrome. We'll be discussing its clinical feature and more importantly, how to distinguish it from its common look like homocystinuria. Okay, so that is homocystinuria. But before we tackle the pathophysiology, we must have a solid understanding of elastin, which I have already made a notes on elastin over here. Okay, so once you understand how this protein is built, the pathophysiology of Marfan syndrome incredibly easy to grasp. So turn your volume up, keep your brain awake, and let's make this topic easy so you can land your dream branch in the medical college. So let's start our today topic. So before talking about Marfan syndrome, okay, so we'll talk about elastin. Okay, so elastin is basically a stress protein. Okay, and you will find it in skin, lungs, large arteries, elastic ligament, vocal cords, epiglottis, and ligamenta flava. Okay, so while talking about its composition, it is rich in non-hydroxylated proline, glycine, and lysine. Okay, now this line is very important. Okay, that tropoelastin and fibrillin scaffolding. Okay, so how we'll understand this, that this elastin start with tropoelastin, okay, which acts like a rubber, liquid rubber. Okay, and to give this tropoelastin organized shape and the ability to stretch and recoil, we need a scaffolding fibrillin, okay, called as fibrillin. So let's understand like this. Okay, suppose this is a tropoelastin, okay, this is a rubber. Okay, so to make it more to give it a more organized shape, okay, so we have a net like structure. Okay, this is fibrillin, suppose this is a fibrillin. Okay, so this fibrillin will come around this, okay, and make it a organized shape. Okay, so to make it a organized shape. Okay, so just remember that tropoelastin is a liquid rubber and it stretches, but and the fibrillin is like a net and it provide organized shape. Okay, so the main why I'm focusing on fibrillin, that if this fibrillin is absent, then it can't hold a shape, and it actually happen in Marfan syndrome. Okay, in Marfan syndrome there is absence of fibrillin. Okay, now like collagen, when elastin form in our body, the cross-linking occur extracellularly with the enzyme lysyl oxidase, as in collagen. Okay, and it give it a elastic properties. Okay, now the second important thing over here is elastin. Okay, so the elastin break down by an enzyme called elastase. Okay, so normally this elastase enzyme, okay, is kept in check by alpha 1 antitrypsin. Okay, so elastase is inhibited by alpha 1 antitrypsin, but sometimes if a patient, or if in any person, if alpha 1 antitrypsin is absent, or the patient is deficient in alpha 1 antitrypsin, then there will be unopposed activity of this elastase enzyme. Okay, then it will break down more elastin. Okay, and that will destroy the elastin of the lungs also, and that will lead to COPD or emphysema. Okay, so sometimes we see in the lung COPD that the patient who have alpha 1 antitrypsin deficiency, then it will cause the elastase enzyme activity more, and it will break down the elastin of lungs, and that will cause COPD. Okay, now this is all about elastin. Okay, now we'll talk about Marfan syndrome. So now let's talk about Marfan syndrome. Okay, so actually Marfan syndrome is a autosomal dominant disorder. Okay, autosomal dominant disorder of connective tissue. Okay, it mainly affects skeleton, bones, heart, and eyes. Okay, so in Marfan syndrome, the main defect is due to mutation in a FBN1 gene on chromosome 15. Okay, so sometimes they ask in MCQ. Okay, so which chromosome is affected? So chromosome 15 and gene FBN1. Okay, so I have already told you previously that if this gene is affected, okay, then there will be defective fibrillin 1 production. Okay, so if fibrillin production is defective, then it will not hold that elastin. Okay, so it will not provide a good shape to the elastin. Okay, so without fibrillin, elastin cannot hold its shape. Okay, so that will lead to Marfan syndrome. Okay, so and also remember that Marfan syndrome are commonly seen in young patients less than 40 years of age. Okay, now we'll talk about the findings of Marfan syndrome. Okay, so talking about the findings, physical findings of Marfan syndrome. Okay, so the patient will typically have long extremities, okay, long face and crowded teeth. Okay, after then chest wall deformity like pectus carinatum, or we can also say that pigeon like chest. Okay, or sometimes also seen pectus excavatum. Okay, then they will have hypermobile joints. Okay, after then long tapering fingers and toes. Okay, while talking about the cardiac complications, so this is the most critical area. Okay, cardiac. So it causes cystic medial necrosis of the aorta. Okay, and it will lead to aortic root aneurysm, sometime rupture or dissections of the aorta. Okay, and you might listen a mid systolic click. Okay, that indicate the mitral valve prolapse. So this cardiac complications. Okay, so cardiac complications is very important because it's the most critical point. Okay, and then the then always remember the most life threatening feature, always remember. Okay, that is aortic root dilatations. Okay, now other features from pulmonary, that is increased risk for spontaneous pneumothorax. Okay, from the apical blebs. In ocular, in eyes we can see ectopia lentis or myopia. Okay, in skin we can see recurrent or incisional hernia, then skin striae and skin hyperelasticity. So the so always remember the most life threatening is aortic root dilatations. Okay, so we'll quickly recap. Okay, the findings that the patient will have long extremities, long face, crowded teeth, chest wall deformity, hypermobile joints, long tapping fingers and toes. In cardiac, we'll see cystic medial necrosis of aorta, aortic root aneurysm, rupture dissections, mitral valve prolapse. In pulmonary, we can see a spontaneous pneumothorax, and in eyes, we can see myopia or ectopia lentis. Okay, then in skin you can see incisional hernia or recurrent hernia, skin hyperelasticity. Okay, now we'll talk about homocystinuria. So we often confused with Marfan syndrome and cystinuria because of physical stature. Okay, but always remember homocystinuria is a metabolic disorder caused by cystathionine synthase deficiency. This enzyme, cystathionine synthase deficiency. So normally what happens is methionine is converted to homocysteine and it is converted to cystathionine and then cysteine. So here this enzyme cystathionine synthase works while converting homocysteine to cystathionine. Okay, so here if this enzyme is deficient, then in the body homocysteine will build up and methionine level also build up. So the presentation will be similar to Marfan syndrome. That's why we get confused. Okay, same that like pectus deformity, tall stature, joint hypermobility, skin hyperelasticity and scoliosis. So now I'll tell how to differentiate and what are decoding features. So now we'll see that how to differentiate them in clinical vignette. Okay, using this checklist. Okay, so always remember this Marfan syndrome is autosomal dominant, homocystinuria is autosomal recessive. Okay, while talking about the intellect. Okay, so the Marfan syndrome patient intellect is normal, but homocystinuria the intellect will decrease. Okay, now while talking about the vascular risk factor, it is the Marfan syndrome is associated with aortic root dilatation, and this homocystinuria is associated with thrombosis. Okay, now while talking about the lens in eye, it is upward and temporal. This one is downward and nasal. Okay, now talking about the complexion, in Marfan syndrome complexion will be normal, and in here in homocystinuria we will see that the patient will have megaloblastic anemia and fair complexions. Okay, so while talking about the treatment of homocystinuria. Okay, so always remember in homocystinuria patient we give vitamin B6, folate, B12, and sometimes we also give antiplatelets and anticoagulants to prevent stroke or congestive heart disease or venous thromboembolic disease. Okay, so this is all about Marfan syndrome. Okay, so I hope this breakdown makes the connection between elastin and these clinical syndromes crystal clear. So understanding the why behind the symptoms is the best way to ensure you never forget them in the exam hall. Okay, so if this video helped you, so please subscribe to my channel at the Dr. Amit Official and give this video a like and share with your study groups. Okay, so thank you.